Hi, good evening and welcome to our webinar tonight, which is called Improving Your Periodontal Cleaning. So my name is Dr. David Clarke and I'm a veterinary dental specialist based in Melbourne, and I have a practice that takes referral cases. And what I thought we would do is each month run a series of webinars. The first one I thought we would cover improving periodontal health. So what I'd like to do during this webinar is to cover periodontal cleaning and talk about periodontal disease. But in particular, I'd like to cover detecting plaque, also probing and taking radiographs and how we can assess oral pathology using probes. And then we can discuss subgingival root planing, both open and closed subgingival root planing, and treatment modalities, and looking at local antibiotic placements and maybe some bone grafting as well over the next hour or so. So what I've done is I've separated and classified periodontal disease into two broad groups. I've based these on age. So the first group are those less than 18 months of age, and the second group are those over 18 months of age. And the first group I've called juvenile, and they get two diseases, the first one being juvenile gingivitis and the second one being periodontitis. And then the adult group, the over 18-month-olds, I've classified into three areas. The first one being adult periodontal disease or slowly progressing periodontal disease. The second one being rapidly progressive periodontitis, and the third one being refractory periodontitis, or as we'd know it as stomatitis, for example, the stomatitis that cats get. So tonight's presentation is going to be focused on slowly progressing periodontitis and periodontal disease, otherwise known as adult periodontal disease. And we'll cover the other groups in future webinars. So as you're well aware, periodontal disease is the most prevalent disease we see in our pet population. It's common. We see it in over 85% of dogs and cats that are 2 to 3 years of age. And the etiology is multifactorial, meaning that there's many factors that have to occur in order for the pet to get periodontal disease. Although we know the primary cause is plaque, because if there is no plaque on the animal's teeth, then there is no periodontal disease. And as soon as plaque develops, then the animal suffers gingivitis. So gingivitis, by definition, is an inflammation of the gum. So initially, I thought we'd just cover some terminology and some definitions and talk about how periodontal disease occurs, and then we'll talk about the other topics that I mentioned previously. So gingivitis is an inflammation of the gingiva. We see that as you can visualize on this slide in the top left-hand corner is a cat with red inflamed gingiva. On the right-hand side, we can see a dog, an upper fourth premolar in both cases. Both have gingivitis, both have red inflamed gums. This is seen by capillary vasodilation, edema of the gums, hyperemia and hyperplasia, and also hemorrhage if we were to touch the gingiva as well. And it's stimulated primarily by plaque, as I said, but there's also a host's immune factor in there as well. If this continues, it progresses onto periodontitis, and we can see by the diagram the periodontal tissues include the gingiva, the cementum, the periodontal ligament, and the alveolar bone. And when we have periodontitis, the disease encompasses all of those four structures. And if you compare that back to gingivitis, gingivitis just includes or just involves inflammation of the gingiva. So the result of gingivitis and periodontitis is periodontal disease. And periodontal disease, by definition, is the structural loss of these four structures. So initially, when the teeth are clean, they're bathed by glycoproteins from saliva and a mixture of bacteria, and this forms a sticky substance which we know which attaches to the tooth as plaque. Initially, when just the bacteria and the glycoproteins are attached to the tooth, then the term is a pellicle, and the pellicle is that sticky matrix that you could scrape off the tooth with your fingernail or remove with a toothbrush. It then thickens and matures and becomes a very diverse community, which is a biofilm, which we call plaque. And plaque is very rich in the gram-positive aerobic bacteria, and we can't see plaque unless we stain it. So when a client comes into the consulting room or you've got the patient on the table, you can't actually see plaque unless you stain it. So the first topic I wanted to discuss in a way to improve your periodontal cleaning is detecting the amount of plaque that's on the tooth surface. And you can do this in two ways. Traditionally, we've used a product called erythrocin. Erythrocin is a red dye. We can see this demonstrated on the upper right-hand picture where the dog has a pink or a red stain on the tooth surface. So the darker the stain, so the redder the stain, the thicker the plaque is. So where the plaque is very thin, then you get a light pink coloration because the plaque takes up the stain. Where it's really dark red, as you can see right near the gingival margin there, there's a large amount of plaque. Another way of disclosing or detecting plaque is to use fluorescin, similar to if a patient came into the surgery with an eye ulcer and you'd take out a fluorescin stick. So you can use fluorescin from the fluorescin sticks, or you can purchase fluorescin as a liquid. Fluorescin is uptaken by plaque as well, and then it's detected using either an ultraviolet or a blue wavelength light. You can use a scaling machine, which is made by the company called Actian, which you can put the fluorescin liquid into the water bottle, and as you actually spray the tooth surface, the fluorescin stains the plaque, and then you can see where the plaque is on the tooth. You can see on the picture on the bottom there, which is the upper fourth premolar of the dog, and you can see the fluorescin fluorescing there and showing the plaque on the upper fourth premolar. So here's a video of myself in the surgery. And what I'm doing is we're painting the tooth with the fluorescin liquid, and then we're going to wash off the fluorescin liquid and then apply a blue light to the mouth, and you'll see that the plaque will fluoresce quite brightly. The light is actually coming from the handpiece from the ultrasonic scaler. So if we were to, and you can see how the area there fluoresces, the fluorescent showing up the plaque. If we were to put the fluorescent in the water bottle and then use that scaler to actually clean the teeth like you would with any other dental that comes into the clinic, scaling off the plaque and the calculus, then what you would find is that you would have a constant recognition of where the plaque is on the tooth surface. So this is a good way, especially if you're getting nurses or technicians to learn how to clean teeth, is to stain the plaque and then use the ultrasonic scaler to remove it. So we ask ourselves, why do we want to detect plaque? Well, I have three areas where I personally and we in the clinic would detect plaque. We would use erythrocin or fluorescin in the consulting room. Firstly, as an aid in educating the client to show them there's actually plaque on the animal's teeth, and sometimes to convince a client that is sort of maybe unwilling to have the patient come in for the professional cleaning, so we can actually demonstrate, if there's not a lot of calculus on the tooth, actually demonstrate to the client that there is actually plaque there and it needs to be removed. On the treatment table is another example of when we might want to detect plaque. So this would be used to determine the extent of plaque coverage on the teeth so that the nurse, the technician or the veterinarian who's doing the cleaning is able to see where the plaque is and how much plaque there is and how they're going to clean the teeth. It would also, I guess, give you an aid in your efficiency of cleaning. So are you actually doing a good job cleaning the teeth, or is your scaler doing a good job cleaning the teeth as well? So there's another reason you could detect plaque. And it also gives you an end point. So rather than keep scaling that particular tooth, you could say, well, now I've removed all of the plaque. You can obviously see the calculus, but you can now see the plaque, so you know when to stop cleaning the teeth as well. And lastly, after the dental procedure, communication with the client in trying to set them up a home care program as well. It aids in seeing whether your home care program is efficient. It also determines whether there's compliance, so whether the owner and the pet are actually doing the home care that you're recommending. And also there's a reason to secure revisits and get clients to come back, because rather than just looking in the animal's mouth and saying to the owner, well, everything looks fine, the owner believes you're actually doing something because you're physically detecting plaque on the animal's teeth as well. So if the plaque attaches to the tooth surface and inflammation continues, bacteria then travel down into the gingival sulcus. And you can see by the diagram on the right-hand side here, the gingival sulcus is that shallow, narrow groove that is defined by the epithelium on the right-hand side. If we look in the circle where the gingival sulcus is, it's defined by where the epithelial lining is on the right-hand side of the sulcus and where the tooth is on the left-hand side. So it's bordered by tooth on the left-hand side and epithelium on the right-hand side. That can be measured. This will be the next step in improving your periodontal cleaning. We'll talk about measuring the sulcus and the pockets. They're normally a half a millimeter deep in cats and up to 3 millimeters deep in dogs. It's a semi-permeable membrane is the epithelium, so any infection in the sulcus can travel systemically to the rest of the body. If the plaque is maintained in the sulcus, then the bacteria there, the aerobic bacteria, utilize and consume all the oxygen and form an anaerobic environment. When there's no oxygen, then the anaerobes proliferate and cause edema and hyperplasia of the free gingival margin, encouraging it to become hyperemic and hyperplastic. It then enlarges and deepens the sulcus, and that changes the whole environment. So you then get a proliferation of gram-negative bacteria, and along with the gram-negative bacteria and stimulation of the host's immune system, you then get all the factors ready for periodontitis. So some of the host factors that we may see are fibroblasts detaching the tooth surface, the epithelial attachment from the tooth surface. The bottom of the sulcus moves apically and makes the pocket deeper. Cytokines come into the equation as well as macrophages producing tumor necrosis factor and other collagenases, which then resorb away collagen in the periodontal ligament and also alveolar bone, thus making the pocket deeper and a much better environment for more anaerobes to proliferate. There's also a host sequence here as well, where a dog with hair around the muzzle, for example, could get caught around the teeth, entrapping bacteria. Animals with systemic diseases like FIV, renal disease, or diabetes, anything that causes stress and vasodilation, not that it's relevant, but in people, smoking, which causes vasodilation, is one of the most common causes of periodontal disease we see in humans. Maybe animals that smoke passively because their owners smoke may also suffer more periodontal disease. There's no proof of that, but it'd be interesting to look into. Malnutrition and trauma are also other causes of hosts' immune factors. So the transformation of the sulcus into the pocket then creates this void. So in other words, the sulcus, which was half a millimeter in cats or 3 millimeters in dogs, now gets deeper, and it now forms a void that can't be emptied or can't be cleaned by either diet or toothbrushing. So we now have a perfect area for the infection to continue. Now, we all know and we all see what we call supragingival calculus, and probably one of the biggest factors in getting clients to actually come in for the professional cleaning would be supragingival calculus. The animal comes in for a skin problem, the animal comes in for a vaccination, the veterinarian, the nurse, or the technician says, Mrs. Jones, your dog or your cat's teeth are dirty, you can see the gingivitis, you can see the calculus, and therefore you book them in for the dental cleaning. Well, not only does calculus form on the supragingival surfaces, as we can see in these two pictures on the right-hand side, we can see there's calculus on the upper fourth premolar and on the first molar on the dog in the top picture there, and we can see significant calculus on the lower picture there on the cat. We've all seen these pictures in the clinic. So calculus forms when the plaque is bathed by saliva and the calcium-rich deposits form calcium phosphate, calcium carbonate, or a carbonate containing hydroxyapatite in cats. But not only does calculus form supragingivally, it also forms subgingivally. And when it forms subgingivally, i.e. under the gum, and it's actually very rough and therefore provides a perfect surface for plaque to accumulate. It actually encourages and enhances, I guess you'd say, enhances the periodontitis and the progression of periodontal disease. It also provides a very rough surface so that the epithelial lining, even if it was to become clean, wouldn't be able to reattach to the tooth surface. In other words, back onto the cementum as well. So subgingival calculus is one of the primary reasons we need to clean teeth and establish a healthy environment. So the next step is to use a probe and determine, do we have a sulcus or do we have a pocket? And why do we need to determine whether we've got a periodontal pocket? Well, these are about 7 reasons I believe that we need to determine, and why we need to determine whether we've got a sulcus or a pocket, and why we need to use a periodontal probe in practice. So the first one is that a periodontal pocket, once it's formed, requires much more advanced treatment than a normal sulcus. It indicates loss of structural tissues. It also provides a place, as I've just mentioned, for calculus to form as well. Generally speaking, when there's a pocket, it may not be reversible. So you may find that the pocket's there to stay, but there are treatment modalities, which we'll talk about at the end, to reduce the pocket back to a healthy sulcus. It may require radiographs. We need to do root planing and subgingival curettage. And also, as a practitioner, you may decide if you've got very deep periodontal pockets, it may be better to actually extract the tooth rather than treat it. So how do we measure the sulcus and the pocket depths? Well, I use a periodontal probe called a Williams probe, which is in the pictures here. I have a double-ended probe. There's a periodontal probe with markings in millimeters. So you can see on the left-hand side, on the bottom left-hand side on the probe, there's millimeter markings. In the Williams probe, it is 1, 2, 3. 4 is missing, and then there's a marking at 5. 6 is missing, and then 7, 8, 9, 10. So that's because when you have the probe subgingivally, you can look for the larger markings, like between 3 and 5 or 5 and 7, and immediately know how deep your measurement is. The other end of the probe is an explorer hook, which we'll talk about in another webinar. There's other probes on the market. Michigan O, for example, has markings at 3, 5, and 8 millimeters. There's many other probes that have markings at 3, 6, 9, or 12 millimeters. The Neighbors probe, for example, has no markings on it at all. So there are many probes, but I personally like the Williams probe. The probe is used by placing it into the sulcus or into the pocket. So underneath the gum or between the gum and the tooth, down into the periodontal sulcus or the pocket, as you can see on the left-hand diagram here. The probe is being placed into that space. And it's being placed far enough into the pocket or the sulcus until the tip of the probe reaches the epithelial attachment. The epithelial attachment is the point where the gingiva attaches to the tooth, in this case just below the cemento-enamel junction. You then take a measurement from the free gingival margin and that will give you the depth of the sulcus or the depth of the pocket. So as I said before, normal in a cat is up to about 0.5 millimeter, and normal in a dog can be up to 3 millimeters. We can see the two clinical pictures. The picture in the middle with the periodontal probe exploring the mesiolingual surface of the cat's canine tooth, mandibular canine tooth, has a depth of around 5 millimeters, so that would indicate a pocket is present and requires treatment. And the clinical example on the right-hand side, we can see measuring the buccal surface, the mesiobuccal surface of the third incisor, the mandibular third incisor there on the dog, and we can see that literally the whole probe has gone down into the sulcus or the pocket there, and it's 10 millimeters, so that would indicate that we have a pocket as well. We need to record these measurements on a dental chart. We'll talk about dental charting in another webinar, but essentially we measure around every tooth in 4 to 6 places, so 2 to 3 places on the buccal surface and 2 to 3 positions on the palatal or the lingual surface. And then we place those numbers that we find on a dental chart. So here we have a video showing use of a periodontal probe in a cat, and what we're doing is we're placing the probe into the gingival sulcus or the pocket and measuring in 2 to 3 places on the buccal surface, and now we're measuring on the mandibular, and then we're going to measure on the palatal surface of the lower maxillary surfaces. So this is probing in a cat. This is an example of using the periodontal probe in a canine, in a dog. So we're measuring in 2 or 3 places again on the buccal surface of the third incisor there, just running it down into the periodontal sulcus. Now just running it along the sulcus of a canine tooth. You can see these are normal pocket depths in this case. And just running along the premolars as well. So now we're just going across the upper fourth premolar on the buccal surface. You can measure in individual positions, or you can run the probe along the entire area there. So I don't really want to and don't have time this evening during this webinar to go through periodontal probing in depth, but you can see that the probe is placed under the gum or beneath the gum into the sulcus or into the pocket, essentially to determine the depth. So on your probe, just to mention again, if you have up to 0.5 millimeter depth in a cat or up to 3 millimeters in a dog, that's a normal probing depth. And if we have greater than those measurements, then we have loss of structural support around the tooth. So we've lost the periodontal ligament, we've lost some alveolar bone, and therefore we need to do other forms of treatment, which we'll talk about after I just mention radiology now. So another way to improve your periodontal treatment success is to take a radiograph of the area. And as you can see in this particular radiograph here, what we're trying to do is we're trying to confirm before treatment that there's no endodontic disease. If we were to clean out the periodontal pocket and place an antibiotic or place some form of bone graft material into that periodontal pocket, then there's no point doing that if you've got an inflamed pulp or an infected pulp tissue. So periodontal disease occasionally will travel down the side of the tooth, around the apex and back up into the pulp canal. So we rule that out by taking a radiograph. And if the pulp canal is symmetrical with its opposite tooth, so if you look at two, say, first premolars and they have the same width of same width of pulp canal, then the pulp canals are healthy. If there's no periapical radiolucency, so in this particular radiograph, you can see that the periodontal ligament, which is the black line that runs between the bone and the tooth, is normal width and thickness around the tooth, then you don't have endodontic disease either. The other criteria essentially is you don't have a lot of mobility in the tooth. If you've lost a lot of structural support, then you'll find that you'll have a mobile tooth and it won't be a good candidate for periodontal treatment either. So in this radiograph, we can see that the thick dashed red line is where the normal alveolar bone height would be. And the black arrows are pointing to the height of the alveolar bone. So we can see that there's a significant amount of alveolar bone loss, but not to say that you couldn't treat that particular tooth. So that first molar tooth still has significant alveolar bone in the furcation area between the two roots, and it also has a reasonable amount of alveolar bone on the mesial root, the root on the left-hand side. About 50% has probably been lost of the length of the root, and on the distal root, probably about 50% as well. So as a rough criteria, what I say is if you could determine when you've got a pocket and break it down into how many walls that particular void has and the length of the root and the amount of loss of structure on that root, that will determine whether the tooth should or can be saved. So for example, a one-sided pocket. So a one-sided pocket would be a case where you've got bone on three sides and you've lost attachment on only one side of the tooth. So a perfect example would be a palatal pocket on the maxillary canine tooth. So if you think back and remember what a dachshund, last dachshund you had, that might have had a periodontal pocket on the palatal side of the maxillary canine tooth, and you put your probe down into the pocket, you've got tooth on one side and you've got bone on the other three sides of that particular void. So that would be termed a one-sided pocket or a one-walled pocket. So you could lose up to 75% of the length of the root in attachment, and that would still be a good candidate for periodontal treatment. Once you lose more bone, as in you have a two-walled pocket, so this would be an area where you've actually lost uh, attachment on two surfaces of the teeth. So for example, this radiograph is a perfect example of a two-sided pocket or a two-walled pocket. If you look at the area between the distal surface of the distal root of the fourth premolar and the mesial surface of the mesial root of the first molar. So in other words, the area between the two arrows on the left-hand side, that void there, that would be a two-walled pocket because you've got teeth on either side. Another example would be if you had a furcation, for example, where you've lost bone in the furcation area and you need to clean out the area of the furcation. So that could be an area where you've got a two-sided pocket as well. So if you lost up to 60% of the attachment in those areas, then you may find that you could actually and successfully clean in that area as well. The worst case scenario, though, would be a four-walled pocket. And this is when you could actually run your probe around the whole root of the tooth. So you've actually lost attachment around the whole of the tooth. So in this case, what you would find is that you would have to have more attachment, so maybe up to 50% attachment in those roots. So if the root is, say, 1 centimetre long, you could have a pocket, say, to 5 millimeters, and you could successfully clean around that tooth, and then you could put medications in there and get reattachment. Now, you may not be able to do that just by doing it blind, which we call closed root planing. You may need to raise a gingival flap, and we'll talk about that later as well. So why do we want to remove the deposits from the root surface? So in other words, why do we need to clean out the pocket before we actually treat the disease? So in other words, if the animal comes in and it's got really severe periodontitis and it's got plaque and calculus and diseased cementum and endotoxins in the pocket, why couldn't you just give antibiotics, for example, or why couldn't you just flush it out? Well, you need to remove the deposits, and you need to remove the deposits for many reasons. But the main one is you need to reduce the amount of plaque that's subgingival in order to get less inflammation. So you want to reduce the plaque to a level where it's not stimulating the host's immune system and producing inflammation and bone loss. You're trying also to establish a healthy environment so we can actually get rejuvenation or regeneration of the periodontal tissues. So you want to get new cementum if you can. You want to get new periodontal ligament if you can. You want to get reattachment of the epithelial lining of the pocket back onto the healthy cementum of the tooth as well. So reattachment is the third one. And also, if you're going to do further procedures, such as place a bone graft, for example, or place a periceutical, or do a restoration, you need a clean environment in order to do that. So how do we actually clean the root surface? So the next step of improving periodontal cleaning is to show you and talk about ways of cleaning the root surface. So cleaning the root surface, in other words, placing an instrument beneath the gingiva and actually scraping and debriding these debris and toxins from the root surface is called subgingival cleaning or subgingival curettage or root planing. There's lots of terms. But essentially what we're doing is we're debriding the root surface and the diseased epithelium from the pocket wall of accumulations, endotoxins, diseased cementum, the hair, the food, the plaque, the calculus, and anything else that's within that pocket. So we use what's called a curette. There's handheld curettes and there's ultrasonic curettes. When we place the curette under the gum, such as in this clinical picture here, and you can't see the end of your curette, we call that closed root planing. If you're to raise a gingival flap and actually visualize and actually see what you're doing, we call that open root planing, and we'll go through both of those now. So a curette is an instrument. It's a hand instrument or it's an ultrasonic instrument, but they look the same. And a curette has a single blade on the end. And as you can see here, there's two types of curettes. The curette on the top is called a Columbia. The one on the bottom is called a Gracie. The Columbia instrument has more of a curve on the blade, whereas the Gracie on the bottom has more of a flatter blade. We tend to choose the instrument based on the curvature of the tooth. So the Columbia instrument on the top, being more curved, is a better instrument, say, for smaller teeth, say premolars that have more of a curve, whereas a Gracie is a better instrument, say, for the flatter surfaces of a larger dog's canine tooth, for example. So there has a blade on the end. The blade is sharp. The blade normally is 3 or 4 millimeters in length, and that connects to the shank, and then the shank connects to the handle. If we were to cut the blade in cross section, it would look like a semicircle. And the other thing which differentiates a curette from other instruments, such as say a scaler, is that the tip of the curette is rounded. You can see where the arrow is pointing to the blade, just above the blade, the end is rounded. The blade also is angled. So when you hold these instruments vertically, there'll be an upper and a lower edge. So you can determine which side of the curette actually is cutting, because only one side of the curette cuts. And now that's important to recognize, because when the curette is in the periodontal pocket, you only want the sharp surface against the tooth root. You don't want the sharp surface against the epithelial tissue, because it's just going to carve it and you're going to have hemorrhage everywhere. So the sharp side, which is the lower of the two sides, is going to be the cutting surface, and that's the side you place against the tooth. If you were going to use an ultrasonic scaler, I believe the only one available is made by the French company called Actian. They make what's called a P5 scaler. It's a piezo scaler, and you can see by the picture on the lower right-hand side that the blade or the tip, which has a blade on it, resembles the curette on your hand scalers. So this makes life much easier, because you don't actually have to do the scraping and the pulling yourself to debride the tooth root surface, you can just let the instrument do the vibrating and the debriding for you. The tip is called an H3, H for Harry 3. It's used in the same action as a hand scaler, so you place it underneath the gingiva, or if you're doing open root planing, you place it against the tooth root surface, and as it vibrates, it shaves and debrides the debris off the tooth root. Now, this is a different type of scaler to your typical magnetostrictives, because the typical magnetostrictive scalers work in sort of an arc, like an elliptical sort of motion, and they're quite rough to the tooth surface, where the new piezo scaler works in a linear fashion, so it's very smooth, so you're not going to get more craters and more crevices on the tooth surface. So you place the blades. So let's look at closed root planing initially. So closed root planing, you won't be able to see the tip of your curette. You place it underneath the gum and you place it all the way down to the base of the pocket. So down into the pocket until it gets to the epithelial attachment. You then put pressure against the tooth surface and then you pull the instrument towards you or away from the epithelial attachment. And as it does that with some pressure against the tooth root, you're actually debriding and removing all the debris that's in the periodontal pocket, as you can see by these diagrams. So the clinical picture on the top, you've placed your curette subgingivally against the tooth surface down to the epithelial attachment. You can then see on the bottom pictures in the diagram, the blade in the middle picture there, you can see the blade is engaging the cementum, and as you remove it from the pocket, it actually removes the debris as well. So here is an example of closed root planing. So you can see that the lower edge of the curette is being placed up against the tooth surface, and as the blade is pulled out of the gingival pocket, you can see that it's actually scraping the cementum and it's scraping the necrotic dentin, and you're removing the endotoxins and any of the other plaque. So you can see that the edge of the curette is actually debriding the periodontal areas, so it's actually debriding the surface of the tooth and therefore cleaning it. So here's an example, two clinical examples as well. So the first one is of a dog, and you can see that the curette is being placed underneath the gingiva up into the periodontal pocket, and as it's being scraped down, you're debriding the root surface. And what you can actually see in these pictures is obviously you get some hemorrhage because you're actually debriding the necrotic tissue off the mucosa and off the internal surface of the pocket as well. So that's an example of closed root planing, which most of us do on a regular basis when we have periodontal pockets. Now, if you're unable to clean the pocket properly, you don't feel you've done a very good job of cleaning the pocket, you feel if you put a probe under there that's still a bit rough and you actually want to see what you're doing, in other words, to do a better job, I guess, or a more efficient job of cleaning the tooth, then what we would do is we'd do what's called open root planing. So open root planing means to literally open up or raise a gingival flap, a mucogingival flap, as we can see in the diagram here. Vertical incision normally followed by a horizontal incision, and you can see how the flap is raised. So this is how we do that. This is an example of a case where the dog has at the moment normal sulcus steps, and then as we get towards the distal aspect of the canine teeth, you can see that the probe goes deep into the pocket. So it's about a 6 or a 7 millimeter pocket there. We don't feel that we can clean the tooth properly using the curette. So we're making a gingival flap, a mucoperiosteal gingival flap. It's important to take the periosteum off the bone as well. um, because you need to clean the root surface, and ideally you'd want some of the periosteum on the internal flap, so it's going to reattach with the fibroblasts back onto the clean cementum. So we raise the flap um, so it hinges at the epithelial attachment, and then lift that up with a pair of forceps, and then using the curette to debride the surface of the tooth. So we're removing, so what I'm doing here is I'm removing and debriding any dead cementum or endotoxins in the cementum and the dentine. And also, you're also noticing that when you get the curette and it's on the bone there, I'm also smoothing off the bone and trying to make the bone smoother so it's not so rough. So you actually get reattachment of the flap back onto the bone as well. Because what you'll find is when you start losing alveolar bone, I suppose technically you've got an osteomyelitis going on, and therefore you're going to have sort of pock marks and little crevices and little deviations within the bone. In this situation right now, where the curette is, you can see that the curette actually goes below the bone as well. So you actually have a higher piece of bone on the distal aspect. So because of that, it's possible to place a bone graft into this area. So what you'll see next is just probing to make sure that we haven't got any calculus there and having filled. Then what I'm going to do is I'm going to place a bone graft, but I'll actually talk about this in about 3 or 4 slides about the different bone graft materials. But this is a calcium phosphate based bone graft, and what it does, it's actually osteoinductive as well as osteoconductive. So it actually stimulates the osteoblasts in that area to produce new bone. So you get new alveolar bone forming. You then will get, because of the cleanliness of the area, and assuming the owner does home care, which we'll talk about in another webinar, will also get reattachment of the epithelial surface back onto the cementum of the tooth as well. And then once the bone graft has been placed, we'll then suture through the flap and through the soft tissue on the hard palate as well. So I'll place, in this particular example, about 3 simple interrupted sutures of something that's absorbable. I personally like Saffold Quick, so 3 or 4 Saffold Quick, but absorbable sutures, 3 across the horizontal incision, then 3 along the vertical incision. So we'll end up with about 6 sutures in total. Okay. So at the end, that will be sutured down, and then we will discuss that with the owner and talk about home care with the owner. And we'll talk about home care in the next webinar. But essentially, we would put the animal on clindamycin for the osteomyelitis. We'd put them on an anti-inflammatory and non-steroidal for the inflammation, and we would use MaxiGuard or Hexarinse in order to control the bacteria in the mouth for the next few weeks until the gingiva reattaches, which normally takes 2 to 3 weeks, and then we'd start toothbrushing. So just going back before we do the bone graft, if we had a small periodontal pocket and we just had, say, 5 millimeters, and it was a one-walled pocket, and we didn't have a large amount of bone loss, then what we could use in order to get reattachment of the epithelial lining of the pocket back onto the cementum is to use one of the antibiotic impregnated gels. So there's quite a few ways of doing this. If you're in the US, in the United States, you can get a product called Doxyrobe. It's only available in the United States at the moment. Elsewhere, you'd need to get it compounded. So in Australia, one of the better places which can compound it is called Slade Pharmacy. If you're in New Zealand, Optimus would be able to compound it for you. This is a temperature sensitive gel. And when the gel is in the fridge or cold, it's actually a liquid. And then when it heats up to body temperature, it becomes a solid. And it's possible to put an antibiotic in the gel, and the gel degrades slowly over time. So over a period of 3 to 4 weeks, the gel will do two things. When you inject it into the pocket, as you can see by the diagram on the top left here as the yellow area, that's the gel that's injected into the pocket. It fills the pocket and therefore prevents bacteria and hair and food going down into the pocket. It also contains doxycycline. So as the gel degrades, the doxycycline is slowly released. And being an antibiotic, it obviously provides antibacterial activities, but also doxycycline has an anti-collagenase effect. So it prevents collagenase, which is one of the enzymes that causes the periodontal ligament to be degraded, to stop, and it also stimulates fibroblasts. So you get reattachment of the epithelium back onto the cementum. So this is just a video of showing how you mix up these solutions. Clearly this was taken in the clinic and the staff were talking and the dog was barking in the background. So when you purchase this as Doxyrobe or as a compounded product, it comes in 2 syringes. The doxycycline comes in 1 syringe and the pluronic gel comes in the other syringe. So it has a life of around 2 years when we purchase it from Slade. Once you mix it up, it has a life of about 2 weeks. So you have to put the 2 syringes together and then mix them up yourself. And it takes about 100 presses backwards and forwards in order to mix the doxycycline into the gel. So I'll just give you an idea of how you then use it. So you have your periodontal pocket. In this case, the pocket is on the buccal surface of the canine. You put the cannula deep into the sulcus, and then as you're injecting the gel, you withdraw the cannula, and I just put a 22 gauge IV cannula on there. And then I overfill the pocket and then use a W3 or a plastic instrument just to remove any excess, just so there's not any exuding out of the pocket. Because what you'll find is that if you have excess, then when the dog goes home or the cat goes home and starts eating, the food will grasp the gel because it will now be solid, because it becomes solid in the pocket, and it will actually extrude it and pull it out of the actual periodontal pocket. So we get those animals back on a weekly basis. We measure the pocket, and we find that each week the pocket gets shallower. And if the dog accidentally or for some other reason the gel actually leaves the pocket, it's possible to refill it, assuming the pocket's not full of hair and debris. But if the pocket's clean, it's possible to fill it back up with the gel in the consulting room. So that's a successful way of using antibiotic impregnated gel for shallow pockets, or for small pockets, if you want to reattach the gingiva. The other way of getting reattachment is to use a bone graft. So the best example is what we call guided tissue regeneration or rejuvenation. This works really well for two cases in particular. It works really well where you have a furcation exposure and you're able to keep the bone graft in the furcation. So it doesn't work very well when you've got gingival recession. You need to have the gingiva there. So you just need a deep periodontal pocket. You need to clean out the furcation area, and then you need to pack the furcation with the bone graft material. Another example would be as the dash hound is another one where you've got a palatal pocket on the maxillary canine tooth, for example. So I use a product called BioResorb. It's a tricalcium phosphate product, and the advantage of that over the others is that it is it is osteoinductive and it's osteoconductive at the same time. So inductive and conductive. Inductive means it actually stimulates the osteoblasts, so you get new bone forming by stimulation of osteoblasts. Osteoconductive means it just sits there as a matrix or as a lattice for new bone to grow through. So the other product which is available, which is called Consul, is an osteoconductive material. An osteoconductive um, in the fact that it is a ceramic bead and it's coated in hydroxyapatite, so it actually allows new bone to attach to it. So this is a case that came in and it had a deep periodontal pocket and I've put the probe. So on the upper left-hand clinical picture, the probe is on the outside of the mouth or outside of the gingiva to show you how deep the pocket is. So the pocket is around 10 millimeters. There's also a draining sinus, which the tip of the probe is in, about 2 or 3 millimeters as well. A radiograph shows the loss of bone. So you've actually lost bone around the distal root. So on the upper right-hand side, we can see that we've lost bone around the upper fourth premolar tooth, the distal root. There's no radiolucency indicating endodontic disease because we can still see the periodontal ligament. So we've lost the bone in the furcation and around the distal root. And I raised a flap. So I made what's called an envelope flap. So I raised the flap, which you can see in the lower clinical slide here, up so that you can actually see down into the periodontal pocket. And then I was able to fill the furcation with the bone graft material. So why would you use Consul and why would you use BioResorb? Well, the main reason is cost and whether you believe you're going to get a better result using BioResorb. So BioResorb is around $400 for a vial and you get about half a cc for a vial, whereas Consul is around 80 to 100, these are Australian dollars, 80 to $100 per vial. So the cost is significant. So some clients may want a cheaper product, but you will get a better result if you use BioResorb. So these are examples of guided tissue regeneration. So hopefully in the last hour or so, we've been through some cases and talked about improving your periodontal cleaning and maybe ways of improving your treatment success. The things I particularly wanted to cover was detecting plaque, because plaque is the main cause of periodontal disease. If you don't have plaque, you don't get periodontitis, you don't get periodontal disease. So you can detect plaque by using either erythrocin or fluorescein. We wanted to use a probe, so I advise you and recommend that we use periodontal probing to determine the depth of the void or the space around the tooth. Do we have a sulcus? Do we have a periodontal pocket? And how deep is the periodontal pocket? We then talked about ways of cleaning teeth, so using subgingival root planing, both using open and closed techniques for getting better ways of cleaning the root surface. So if you feel that you're able to clean the root by not making a flap and doing closed root planing, that's great. If you don't feel you have the dexterity or the skill to clean the root surface, then you may need to raise a flap. One really good technique to see whether you're cleaning the roots properly is to pick a tooth that you know you're going to extract and then clean the pocket as best you can. And then once you've extracted it, you can see how much plaque or calculus is left behind. And that's a good way to improve your subgingival cleaning. And obviously, if you do open root planing, you'll improve your cleaning as well. And there's two ways of treating that pocket and avoiding it just filling up with hair and plaque again. One way is to use an antibiotic impregnated gel, such as Doxyrobe or one of the compounded products. And then the other way is to use one of the artificial bone delivery systems, such as Consul or BioResorb as well. So hopefully this has given you an idea of ways you can improve your periodontal cleaning. And I'm going to chat to Ian and John, who manage the website, and we'll put this talk, we've recorded it, so we'll put it up onto the website in the next couple of days as well, so you can go back and review it. And also we'll send you an email on some of the products that are available, so you don't have to go searching for them. That'll make your life a little bit easier. And also I'll send you an email and talk about our new website. So I'm got a new website which is www.vdec, which is Veterinary Dental Education Centre, and on that we're going to run the monthly webinars, and we're also going to provide various techniques and procedures as well, and some case studies as well. So that's being developed. It's available now, but it's being developed. It's obviously going to provide a lot more information over the coming weeks and months. So thank you very much for your attendance tonight. And the next webinar will be on October the 13th. So my plan is to run a webinar every second Tuesday of the month. And the next topic will be on home care. So thank you very much for attending.